very few cases are being done right now, although we have BRS in India and everybody knows about it. Yeah, so please go ahead.
Good afternoon, everyone. I think the topic is having a re-look at BRS. I'm not here to advocate BRS as a therapy for bifurcation stenting, because we've learned our lessons, and over the next couple of minutes, I'll just take you through the journey of the BRS. Yes, this is one stent scaffold which is desirable. It has multiple advantages as listed. It restores your vessel vasomotion. It basically dissolves over a period of time, so leaves the branches open for re-intervention. And you would not like to leave behind something which kind of becomes a nidus for some problems to come up, restenosis, neoatherosclerosis. And yes, these vessels at a future date are graftable. Well, we've learned our lessons from Absorb, and we noticed a very high rate of early as well as late thrombosis with Absorb because of mechanical and biological reasons. Mechanical primarily because the struts were very thick, so it led to compromise of the lumen and thrombus formation. There were also strut fractures because the protocols were not being followed, and since the struts were thick, the endothelialization was delayed, and that led to its own set of problems.
Can I interrupt a little? Yeah. Because the next session live case is ready.
Right.
So if you can tell us the more salient points and make it a little faster.
Fair enough, I can forego the talk also.
Yeah. No, I think we can have some of the important points.
Okay, fair enough. So the lessons from the Absorb were that the stent thrombosis rates were very high. So they kind of revised their protocol to PSP, wherein they said you pre-dilate, you size the lesion well, and do the post-dilatation, and that was the way forward. But did it help? Yes, it did help. It brought down the thrombosis rate. But when you look at Absorb 4, the problem still persisted. So the problem, since it persisted, there were certain challenges, and as listed on the slide, the struts were very thick. There was compromised radio opacity, so people using in an overlap fashion had problems. It had to be stored in a cold chain, had to be maintained for the quality, and one could not overlap these struts. So there was a need to improve the device. There was a need to improve the technique to implant this device, and kind of features which are given here. The strut thickness was very thick, and we have the new platform Mirus, which has brought down the strut thickness from 150 to 100. They have also given a couplet of radio opaque markers at each ends which help you in implant, and yes, the size matrix has increased. Well, this is Mirus 100, and all the features which I enumerated. It's got a hybrid closed cell and open cell design, and you can see the radio opaque markers, and they help you implant the stent better. And if you see that this slide shows the dissolution rate is pretty good, and there are studies where it has shown that the strut dissolves over a period of 2 years of time. And the deliverability, since you have a very bulky stent with Absorb, the deliverability was questionable here. It goes to the 6 French, and it goes very easily. But if you have tortuous anatomies, you have to be careful. You have to use the guide extensions. Now, what are the important things to remember? You need to select your patient well. It's essentially meant for young patients. You need to prepare the lesion well. Yesterday we saw a case, there was a little bit of calcium. You need to crack that calcium. The BRS is not a platform to use for vessels more than 4 millimeters, because you can't overexpand and blow it up. You need to pay attention to the expansion limits. You can blow it up only by 0.5 millimeter. You can't keep blowing it up further. And this needs a very dedicated protocol for expansion. You need to go up slow. You need to maintain pressure. It's not like a metal platform. You go to 16, 18 and come down. You need to stay there for time, and DAPT has to be kind of cemented onto the patient, and you need to have a separate session with the patient that he needs to continue the DAPT well. Well, the Mirus platform, they have paid attention to all this. These are specific markers which are available, and if you need to overlap, now the balloon marker, the distance between the balloon marker and the stent is about 1.3 millimeters. So once you overlap this, you match the balloon marker with the previous stent's radio opaque marker, and then when you go up, you have a perfect overlap. So this kind of overcomes the shortcoming of Absorb, where it was not possible to have this kind of overlapping without the struts getting on top of each other. Well, the following situations you should avoid in tortuous anatomies, complex CTOs or calcific lesions or very small vessels. I'll just show you two straightforward cases of RCA. We've dilated and these are the images. It's very important to have the reference diameters because this is what will help you select the sizes. OCT scores override us in this regard, and malapposition is a norm, and I'll show you the images that whenever you implant these stents, you'll have malapposition, so you need to post-dilate. So this is the kind of malapposition you will see around the struts, and you need to optimize. Another case of RC, again a garden variety, you do the sizing, and this is how it looks on boost. You can see the arrow markers on stent boost. Rest nothing is visible. So the triaxial markers are very well seen. This is post-stenting and a very well opposed stent. Little bit of malapposition as a norm, I told you. And this is an image which a rendered view of a stent shows. You have the guide wire, you have the stent struts. These are the open cell designs, and at each end you have closed cell design. So you can have 3D images also available to show you whether the stent is expanded well or not. It's been tried, and Dr. Praveen has been part of these trials. 2 have been completed, 1 study is ongoing. What is important to note is that the scaffold thrombosis has come down tremendously, and they haven't recorded even a single scaffold thrombosis. So the strut thickness reduction, the storage change, the protocols being advocated for a proper implant have been followed, and that has really helped in producing good results. But yes, they have been very cautious in advocating this stent. And to conclude, I would say that the new generation Mirus is here, and but the caution here is that if you want good results with this, you have to follow a protocol, select your patient well for implantation. You just can't do it in anyone or everyone. I'm not advocating it for calcified tortuous or for multi-vessels or for bifurcation anatomies. Use imaging, which is very, very important, and follow up your patients well with DAPT, because this is what is going to ensure good long-term results. Thank you for your patient hearing.